Happy to be with you today. Today's presentation is entitled Social Isolation is a Potent Killer. And I think you'll agree after you see some of the data that we're going to present in this talk. Social isolation is bad for health, as is smoking. Indeed, Holt Lundstedt and Associates have suggested that social isolation is as dangerous to your health as smoking 15 cigarettes a day. Social isolation has been associated with psychological distress, cognitive impairment, poor self-rated health and well-being, neglect of desired health practices, an array of health ailments, mortality, and indeed even the common cold. There are diverse physiological, behavioral, and mental health effects from social isolation. One critical element is the chronic elevation of stress mechanisms, whether it be the hypothalamus, the pituitary, the adrenal axis, the sympathetic nervous system, are all elevated by social isolation. Isolation also impacts coping-related health behaviors: smoking, diet, physical activity, alcohol. So social isolation has also been associated with elevated vascular activation and fragmented sleep, impaired immune function, slower healing, depression and anxiety is associated with social isolation, lack of support to cope with health problems. You neglect your health if you're more socially isolated. Lack of normative pressure from peers to engage in good health practices. And even among very young children, the physiological and social priming that's due to insecure childhood attachment can actually result in impaired neurological development. So let's turn the coin over and ask then the question, how do social ties promote health? And I'm going to suggest four major ways. One is that social ties help us at times of illness. They also promote good health practices, encourage us to do the right things. The social ties actually help us buffer stress, and they stimulate our immune system. So you can think of these are four ways in which it's positive to have strong social connections. However, it's been difficult to figure out how to measure social ties, how to measure social connections. One could develop a measure that focuses on family, perhaps friends, and there are some measures that look at social engagement or social group activity as a way to get at social connections. Some time ago, in fact 40 years ago, when I was working in California, I developed a social network scale that was used in a statewide home health care program. This scale was a 10-item scale. It was focused on family and friends. It was highly correlated with clinical assessments of social isolation, and its psychometric properties are well documented. Indeed, it's been used extensively in research studies, and over 1,000 citations are available that use this original scale published in 1988. A few years ago, Melanie Gironda and I developed a revised version of the Lubben Social Network Scale, and we also developed an abbreviated version. The revised version had 12 items. The abbreviated version had 6 items. This was because with the original 10-item scale, we got a number of requests where people wanted a shorter version to be included in various research studies or in clinical practice. And so we wanted to have it standardized so that we wouldn't have a proliferation of different abbreviated measures. So we developed the 6-item measure. Now the lead-in for the revised as well as the LSNS6 for family is considering the people to whom you are related by birth, marriage, and adoption. the lead-in for friends is considering all your friends, including those who live in your neighborhood. Now, the internal consistency, the Cronbach alpha for the LSNSR is 0.78. The Cronbach alpha for the LSNS6 is 0.77. So you can see their psychometric properties are somewhat equivalent. And I think as a result, many people are now favoring the LSNS6 over the longer version of the LSNS. Some researchers still prefer the LSNSR because it does give them more data. But in practice, the LSNS6 is clearly the preferred instrument. Here are the 6 items that make up the LSNS. There are 3 items that deal with family and 3 items that deal with friends. The first item is, how many relatives do you see or hear from at least once a month? The second is, how many relatives do you feel close to such that you could call on them for help? Perceived social support is the nature of this item. And the third item is, how many relatives do you feel at ease with that you could talk to about private matters? This is sort of getting at confidant relationships. And then we go through a very similar series of 3 questions for friends. How many they see at least once a month, the perceived social support item, and then the confidant item. We did some research in Europe recently that we published, and we used the abbreviated version, and we used the clinical cut point for the abbreviated version. And you can see from the correlation coefficients on the screen that this measure was highly correlated with an array of health and mental health outcome measures. And it was correlated at similar rates in Hamburg, in London, 2 large cities in Europe, and Solothurn, which is a rural community in Switzerland. We did another study, this is out in Los Angeles with Kaiser Permanente, where we were looking at the risk of isolation, or the risk of dementia rather, and the role isolation may play. And what we found in this 4-year follow-up study, so this is a proactive study, that those people who had stronger social ties, that is to say they were not socially isolated, were only half as likely to develop dementia during the 4-year period after the baseline survey. And also it was significantly rated, 1/3 less likely to develop dementia after 4 years after we in our models controlled for such things as education, age, and a selection of different health conditions. Loneliness is frequently associated with social isolation. These are 2 different constructs, but we need to oftentimes consider them at the same time, in part because the interventions that would be designed for one often are interventions that could be effective for the other. Hockley and Cacioppo suggest that loneliness is perceived social isolation. Hockley and associates in another study said that loneliness is the painful feeling of social isolation that accompanies perceived deficiencies in the number and or the quality of one's social relationships. So you can get the sense that loneliness and isolation have a connection. There are other manifestations of social isolation. If you're in health settings, particularly emergency rooms, you probably encountered the term unbefriended older adult. This is an older adult who may show up in the emergency room, may be cognitively impaired, doesn't have family, doesn't have friends, and of course, therefore, it's hard to get consent, but it's a real challenge then in terms of developing a care plan. Another term you may come across is elder orphans. These are older adults who sometimes outlive their relatives and their friends, and they end up in old age without much of a social network. Again, a phenomenon that you're going to encounter in practice. Now, the clinical assessment of probable cause of social isolation was a study that we did back at UCLA. And here I had social workers in a study of older adults. We had the social worker assess these older adults, identify a group that they perceived to be socially isolated, and then I asked the social worker to identify what they thought the most probable cause was for the social isolation. 30% of the cases, the social worker said the person was a lifelong isolate. They always, throughout much of their life, appeared to be fairly much a loner. 28%, it was a bereavement circumstance. 18%, it was a health issue in the older adult. And 13%, the older adult was perceived to be isolated because of caregiver strain or caregiver burden. Now, these probable causes suggest interventions that we might develop, but they also suggest that one size doesn't fit all. So as we develop interventions, we cannot assume that it's going to address all the needs there are for social isolates, but they have to be tailored for the particular cause of isolation. For example, bereavement counseling and support would be appropriate for those who are isolated because of bereavement. We also need to address health issues if that's the cause of isolation. Caregiver support groups or respite programs be appropriate for those with caregiver strain, and we're going to have multiple approaches for lifelong isolates. Indeed, we all need to become more socially connected. One of the things that I've found fascinating in my career is that retirement planning is almost preoccupied with building a financial nest egg so that you have financial security in old age. However, I think it's just as important that we be concerned with developing social capital. Indeed, social capital is essential for enjoying a good life in old age. Now, there are practice implications of social isolation of older adults. One is that we need to consider social health to be just as important as physical and mental health. We also need to integrate content on social isolation into the curriculum for all healthcare providers so they know what to do with social isolation, how to identify it, and know what some of the options are, just like they learn about other health risks. And then also we need to develop social isolation assessment protocols in geriatric practice so that we assess for social isolation. If you don't assess for it, you're not going to consider it in your treatment plans. If you don't assess for it, you're sending an implicit message to the older adult that it's probably not that important, when we now know it clearly is important. Implications for policy: we need to develop strong communities that support social ties. We need to have policies and programs that address social isolation. And we need to support more research on the cause of social isolation and understanding what programs work and for whom. Fortunately, there's been a tremendous report that just came out early this year, early 2020, a consensus study report from the National Academy of Science, Engineering, and Medicine. There's the URL. You can get a free copy of the report if you want to read more. Additionally, you may want to look at some other resources I'm going to give to you momentarily. But meanwhile, I want to summarize by saying that we need to give more attention to social ties in geriatric practice, gerontological research, education, in our own personal lives. And here's the resource I was going to mention earlier, and that is that Boston College has a website at the Institute on Aging with a series of videos. These are free videos that address social isolation. So thank you very much for your attention. I look forward to our question and answer session.
Hello, my name is Sato Ashida. I'm an associate professor in the Department of Community and Behavioral Health at the University of Iowa College of Public Health. My research focuses on understanding social networks and social relationships and how these factors relate to our health and health-related behaviors. You just listened to Dr. Lubben's presentation on social isolation and health, and he also gave you a great overview of the key social network and social support concepts. So in this presentation, I just want to focus on presenting the data, social network data that I collected with older adults here in Iowa, so that we can bring back those concepts and key knowledge that we have about those concepts home here in Iowa to inform our practice as we work with our population. So we just heard how positive social contexts can support the health and well-being of older individuals. So in this study I want to present today, I focused on social relationships that involve active engagement among older adults. We know from the literature that just being present in social setting is not sufficient, and we want to focus on active engagement. Although some interventions led to the reduction in social isolation among older adults by adding social network members, such as sending college students to do friendly visits, or having social workers or case managers or volunteers make phone calls to older adults so that they are having social connections to reduce social isolation. However, these interventions were not always successful in reducing the feelings of loneliness, which is also important, as Dr. Lubben discussed in earlier presentation. This may be because most older adults have existing social network members, including their family and friends, but for whatever reasons, they are not interacting at the level older adults desire, or not in a way that older adults want to interact with them. So this highlights the importance of assessing older adults' existing networks to identify sources of social resources that may be available to facilitate their well-being and can be activated in their current systems. Before I talk about my study, I want to provide a quick overview of the functions of social network systems. So those are the social resources that are available in our networks that have implications on our health and well-being. Social support is the most well-studied, well-known construct in social networks. Those are basically the social interactions that involve the exchange of social support with an intent of being helpful. Social connections or engagement, social relationships that allow individuals to be connected to others is also very important. As humans are social beings, we need to be connected to other people to maintain our health and well-being. Social influence can happen when you are receiving encouragement or suggestions from your family and friends. They might be encouraging you to engage in activities. They might be encouraging you to eat healthy or go to the doctor's office. So those are the positive forms of social influence. And finally, there are interactions that may not be so positive, involving conflicts and unwanted advice. Studies have shown that such negative interactions can have bigger impacts on our well-being than the positive impacts that social support has. So it's very important that we consider both negative and positive interactions in these studies to understand how social relationships can be intervened upon to enhance our health. So in order to inform future public health strategies, I posed these research questions. One, I wanted to identify social relationships that bring important social resources to older adults, because these are the relationships that we want to enhance and retain. And if someone doesn't have such relationships, then we want to identify existing members who could be having such interactions with them. And for this, I sought to see the social resources network members who co-engage with older adults bring that can be health enhancing. The second question, I wanted to identify key sources of resources, so that we can identify network members who can tag as potential sources of resources when needed. Literature shows that the extent to which network members bring social resources may depend on their relationships, for example, if they're family or friends, and also by the location of those network members, with, of course, locally located members being able to provide more resources. So this study was conducted in Otama, Iowa, a few hours drive down from Iowa City. And we had 133 participants completing one-time face-to-face interviews. We recruited those individuals in partnership with the local area agency on aging through their services. We also went to their meal sites. We went to some social groups, and we went to senior housing to recruit some folks for the study. We also had participants who were referred into the study by those who already participated. As we were working with groups in senior housings, those who had participated had told other people that it was fun to participate in these studies. That helped us a lot. So assessing their network systems, we first ask participants to enumerate their social network members. So basically identifying their social network members by asking 3 questions. So first of all, we asked respondents to list close family members, including spouse, parents, siblings, children, and grandchildren, so that we could make sure that we captured their close family network system. We then asked them to identify anybody who lives or who had lived in their household during the past 12 months, because cohabitants are very important, as we know. And also we asked them to identify anybody else who played a role in their lives, either positive or negative, during the past 12 months. And by looking at the list of individuals that they enumerated, participants identify people who fit into many different types of descriptions. So, for example, one, to identify people who they co-engage with, we asked them to select network members with whom they engage in social or recreational activities together. For social support, we ask who gives you emotional support, instrumental support, companionship, who provides you with good company and companionship. In social influence, we ask them who encourage them to eat healthy, to exercise, go to the doctors, get flu shot, and so on. And for negative interactions, we ask them to identify individuals who tries to control or influence their lives, or who gives unwanted advice. So those are the characteristics of the participants and network members. 133 participants, mean age of 74 years, ranging from 60 to 91 years. Majority white, female, and about half of them were living alone at the time of the interview. Those 133 participants enumerated 1,731 social network members. So this is our data point. We had 1,731 social relationships to analyze in our data. The mean age of the network members were 58 years, age ranging from 0 to 99. Quite a few participants reported great-great-grandchildren who were just born. So that was exciting to hear. About half of those network members were their family members, and 70% were their local members. On average, participants enumerated 13 members, social network members, ranging from 3 to 32, indicating that some of those participants had very small social network systems, a number of 3. About a quarter of those network members are local family, another quarter non-local family, and 44% were local friends. There was very small number of non-local friends. So also results I'm presenting today, we made a comparison between the 3 groups. So comparing local friends as opposed to local family and non-local family. So this is the first set of analysis looking at whether social relationships that involve co-engagement in activities bring more social resources than the relationships that do not involve co-engagement. And as you can see all across the board, the relationships that involve active co-engagement brought more social resources than the relationships that do not involve active engagement in social activities. So for example, the relationships that involve co-engagement were almost 10 times more likely to bring companionship and 3 times more likely to bring other types like informational support and emotional support. We then looked at who brings those resources. So those are descriptive statistics. For example, if you look at the frequent interactions, Frequent interaction is defined by interacting with a participant at least once a week, either in person, over the phone, or over the internet. So out of 1731 network members, about 70% of them were interacting with the respondents frequently. And of those who interacted with the respondents frequently, 28% were local family, 16% were non-local family, and 53% were local friends. So what we're seeing here across the table is that family and friends are sharing social roles on most tasks. As you can see, they're almost equally sharing the social roles. So half of those providers of resources are local friends, and the other half were family, combining local and non-local families. For example, emotional support, about 52% of the providers are family, both local and non-local, and 42% are friends. We see similar patterns for informational support and companionship. And when it comes to negative induction, however, we shouldn't be surprised by this, I think, that local families are the winner, while non-local family and friends are equally identified for negative interactions. So these are the results of hierarchical logistic models predicting the likelihood of network member providing the specified type of social resources specified at the top of the table based on the network member groups. So network member groups meaning local family, non-local family, local, non-local friends. So those analyses controlled for all the participant level and network member level demographic characteristics. So controlling for those individual and network member differences, we saw some differences in the roles that social network members play, and there were differences between network members of the individuals who lived with others as opposed to who lived alone. So I'm just going to highlight a couple of results on this slide regarding the frequent interaction and companionship. So for those who live with others, family members and friends were generally equally important to them. However, when you look at individuals who live alone, local friends were more likely to frequently interact with the participants and provide more companionship compared to their family members, either local or non-local family members, merely highlighting the importance of those friendships in their daily lives. So summarizing these findings, we saw that social relationships that involve active engagement in social activities are very important to older adults as they bring all types of social resources that are health enhancing. We saw largely that family and friends share social roles, providing resources about equally to older adults, and that friends may be especially important for those whose family members may not be readily available, for example, living alone. We saw that friends may be actually stepping in to provide important social resources to those older adults who are living by themselves. So overall, we were able to document that older adults naturally occurring networks have many sources of social resources, both family and non-family, and that some sources are active while others can be activated when needed. As for future steps, for practice, we can use these measures that I introduced to you today to identify important social relationships and important types of interactions. Then after we identify those relationships and interactions, we can support older adults to enhance or maintain those relationships in their daily lives. If we see some of those important relationships ceasing, then we may step in to provide assistance so they can maintain those relationships, or if we need to provide alternative social relationships, social ties that they can develop and enhance. We can also activate some of the inactive relationships, inactive social ties, and change the frequency and type of social interactions that they have with older adults through public health interventions. In terms of research, we can implement these network interventions and assess its impact on social, emotional, and physical well-being of older adults. We may also pay attention to assessing the role of structural support. For example, we may want to steer and maintain the funding or programming to allow older adults and their network members to continue to co-engage in activities and exchange resources. So this is all I have for this presentation. Thank you so much for your attention. I just want to quickly acknowledge that this study was funded by the University of Iowa Prevention Research Center, which is funded by the CDC. Thank you for your time.